Hello and welcome to our class. This is Pharmacological Treatment and Substance Abuse Counseling Week 1. In this lecture, I will cover the highlights of Chapter 1 in your textbook. And just like with a traditional face-to-face class, please use this lecture in addition to your textbook and rather than as a replacement for your textbook. I'm happy to have you with me. Welcome to the class and let's get started. Drugs can have several different names, and it's important to understand these different types of names before we start talking about specific drugs. The first one that the book goes through is chemical names. These are names that are very specific. They reflect the molecular structure of the drug. The example in the book is 7-chloro-1,3-dihydro, 1-methyl, 5-phenyl, 2-hydrogen, 1,4-benzodiazepine, 2,1, which clearly is hard to say, hard to remember, very clumsy, but also very specific, and to a chemist it does mean something very specific. The next level of name is a generic name. In the book, that same name that I just stumbled through is diazepam. This is just the generic name for this molecule. It's not a brand name, which is the next level. So a trade name is also known as a brand name. And in this case, this example is Valium. Now this is a specific formulation. It's been developed by a pharmaceutical company, and it's for sale, marketed by that pharmaceutical company. It means, again, something fairly specific, but it doesn't give you that level of molecular detail that the chemical name did. Finally, the street name is common for recreational drugs that are sold on the street. It's what drugs are known as colloquially. So in Valium's case, it'd be known as downers or tranks or something along those lines. In science, we use the metric system, and drugs are most often measured in milligrams, which is 1/1000th of a gram, or 0.1% of a gram. But then there's also different factors that affect how the drug is absorbed into your body. Your body weight makes a difference of how big of a dose you might need to take of a drug, and other factors as well, such as whether you've eaten recently or what you've eaten recently, if you have a tolerance to a certain drug, things like that, which we'll talk about later. But just remember that if you take 200 milligrams of a drug, that doesn't necessarily mean that 200 milligrams are in your blood and having an effect. A dose response curve shows what effect you get at different doses of a drug. And this should go all the way from very low, such that there's no effect, to high enough that there's no additional effect, plus have several points in between those extremes. So here's figure 1-1 that shows on the vertical axis the effect of caffeine, and on the horizontal axis different doses of that caffeine. And you can see that at the highest doses it's actually dropping off, the effects going down. So the idea here is that it's not necessarily true that higher doses give you higher effects. It's helpful to describe these curves using different shorthands. Some of those that are commonly used are the ED50, that's the median effective dose, or the dosage that is effective, however efficacy is defined, the dose that's effective in half of the population. LD50 is the median lethal dose, and that dose would be lethal in half of the population. Obviously, with humans, you can't define an LD50 dose, so instead you talk about a TD50, that's toxic in half the population. However you define toxicity or dangerous side effects would be the TD50. You can also use the shorthand to talk about with different numbers. Maybe the 1 would be the dose that's lethal in 1% of the population. The ED 99 would be the dosage that's effective in 99% of the population, and so on. A helpful way to talk about a drug's safety is to consider its therapeutic index, or TI. This is defined as the LD50 divided by the ED50. For example, assume a drug, we're going to call it drug A, has an LD50 of 60 and an ED50 of 5. You can calculate the TI for drug A. To calculate that therapeutic index, you divide the LD50 by ED50, so that in the example from the previous slide, that's 60 divided by 5, or 12. So the therapeutic index is 12 in this case. Then, for example, let's say another drug has an LD50 of 100 and an ED50 of 80. The question is, which drug is safer? Again, to calculate the therapeutic index, you divide LD50 by ED50, and in this case it's 100 divided by 80, which gives a therapeutic index of 1.25. So comparing drug A's therapeutic index of 12 to drug B's therapeutic index of 1.25, drug A is far safer. That is, the therapeutic index of 12 means that you've got a lot higher window in which the drug is efficacious and not lethal. You want that therapeutic index to be as high as possible, meaning you've got a lot of leeway in a drug being efficacious without being lethal. Potency and effectiveness seem like they should be the same thing, but they're not quite, and to explain that, take a look at figure 1-3 for an illustration of that. Potency basically means a low ED50 of a drug. It means that you don't have to give a high dose of the drug to see a response. So that's comparing drug A to drug B. Drug A has a lower ED50 and is therefore more potent than drug B. Effectiveness is differences in the maximum effect that the drug could produce at any dose, at its maximum dose, at the maximum dose, the maximum response on the DRC. So that's comparing drug C to drug D on figure 1-3, where maybe they have the same ED50, so they're just as potent, but drug C has a higher maximum effect. And the book compares morphine to aspirin for analgesic effects to describe how a drug might be more effective. Morphine is clearly more effective at relieving pain than aspirin at very high doses if you have very high levels of pain. A drug's primary effect is the intended effect with treatment. Whatever you're using that drug to treat for, that's its primary effect. Some drugs do have multiple desired effects, and in those cases, the primary effect changes with the intention of treatment. So one example is aspirin, where it can be a pain reliever or a fever reducer, or keep your a blood thinning agent, keep your blood from clotting. So depending on the reason why you're taking aspirin, any of those might be the primary effect. And those other effects would then become side effects. Secondary effects or side effects are any other effects, any unintended effect of the treatment. Whether this is harmful, beneficial, or neither, benign, these are called secondary or side effects. So again, if you have a headache, you can take an aspirin, and if it happens to also reduce your fever, then that's a beneficial effect, for example. There are several different types of drug interactions to be aware of. One is antagonism. You know what an antagonist is in a book or a movie, so a drug antagonist is something that decreases its effect, whether it increases its ED50 or it decreases its potency. So in figure 1-4 in the book, you can see the dose response curve A given an antagonist might go to dose response curve C or D, where C is greater ED50 and D is greater in ED50 as well as decreased potency. The opposite of that is an additive effect, where a drug might decrease the ED50 or increase the potency of a drug. So the example in the book there is going from curve A to curve B in figure 1-4. And then a super additive effect or potentiation is when combining drugs gives a bigger effect than what you might expect. It's often hard to determine whether there's an additive effect or a super additive effect, but basically potentiation just means that the drugs aren't simply adding on top of each other. They're doing something in the physiology of the body that's making each of them more potent or more effective. Pharmacokinetics deals with what happens to a drug when you take it, and typically it's broken out into several different parts. First is absorption, how a drug gets into your blood. If you inject it directly into your blood, then it's obvious how it got there, but if you inhale it or take it as a pill or any other route of administration, then it's worth talking about absorption. Distribution is what happens to it once it's in your blood, where it goes in your body, where it exerts its effects. Third, the book skips over metabolism or kind of lumps metabolism in with excretion. So you can consider these things together, metabolism and elimination or excretion is how the drug leaves the body. But really, I think metabolism is worth breaking out, so that's why I'm noting it here, is really how the body deals with the drug, what happens to the drug when it's inside. Typically it's broken down into different parts, and then excretion and elimination is separately how the body gets rid of those parts, those metabolites. And then sites of action the point here is just that not all areas of the body are affected equally, and many drugs exert their effects in some places and not in others. There are several different ways that a drug can get into your system, into your body. The formal term for this is routes of administration. So a drug can be inhaled, you can take a drug orally, you can use transdermal patches, imagine a birth control patch or a nicotine patch, something like that. And then there's also, you can inject a drug, and I thought that was worth breaking out to define different types of injections. Subcutaneous means it's injected just under your skin. You can imagine if you've ever been tested for tuberculosis, you know the bubble of fluid that's injected right at your skin. Intramuscular means it's injected into your muscles, and then intravenous is into your veins. There's other ways that drugs can be injected, but they're not nearly as common. And this is important because the route of administration affects how quickly the drug is in your bloodstream, and therefore how quickly it can have an effect. The way drugs are absorbed from injection sites is through the capillaries. Capillaries are tiny blood vessels that deliver nutrients and carry away waste throughout your tissues. And drugs need to be in the bloodstream to have their effect. So as blood flows past the injection site through these capillaries that reach all the different injection sites, whether they're intramuscular or subcutaneous, whatever it might be, the drug can diffuse into the capillaries. Diffusion is just a passive event where substances can move from areas of high to low concentration until it reaches an equilibrium. So the book gave the example of putting some food coloring into some water, and sure enough, the food coloring won't stay concentrated in one little area, but it'll spread out through that water until it's at equilibrium. A depot injection is where a large amount of drug is injected all at once and then released in a controlled manner over weeks or a month. The book gives an example of antipsychotic drugs as a good depot injections being a good way to deliver antipsychotic drugs. Basically, getting one injection per month or so increases the number of patients who stay on the drug as it's prescribed. They can't forget to take it. They can't stop taking it if they're feeling good, or stop taking it if they're experiencing difficulties with side effects. They have to have an injection once a month, and then they're covered for that number of weeks or month or whatever it is. This is an illustration of the circulatory system. It's figure 1-5 in the book. The heart pumps freshly oxygenated blood to the body through arteries, and then the blood goes into the capillaries to reach all the tissues. And again, the capillaries are where oxygen is delivered to tissues and waste products are absorbed back into the blood. Then veins return the blood to the heart, where it's pumped to the lungs to be freshly oxygenated, and the cycle repeats. This is essential to keep tissues healthy, so the circulatory system is very efficient. And when gases or vapors or mists are inhaled, they're distributed through the circulatory system, so distribution is pretty quick. Drugs that are smoked or snorted are still administered through the lungs, at least partially, but they can't be exhaled, so we excrete these in other ways. You already know drugs that can be smoked, tobacco, marijuana, and others. The problem with smoking is that the respiratory tissues can be damaged from chemicals in the smoke. So this is not just the active drugs, but also tars and hydrocarbons and so on. And you've heard about that. Intranasal administration is snorting of drugs. One example of this is cocaine. When you snort a drug, the moist membranes in your nose, the mucous membranes, allow the drug to be absorbed into the blood, but some of that drug is absorbed through your lungs and some is absorbed through the digestive system. At least that's what we think. Drugs taken orally are primarily absorbed in the intestines. The intestines are lined with capillaries because this is also the primary site where nutrients from food are absorbed. So to pass from the intestines to the capillaries, drugs need to diffuse through a membrane, such as that shown in figure 1-6, or be transported across the membrane, which we'll cover a little bit later. So lipid diffusion through a membrane, which the membrane is made of lipids, is why lipid solubility is important. Lipid solubility is how well a drug dissolves into fats as compared to water. And one way to test this that the book covers is the olive oil partition coefficient. You can mix a drug in a mixture of both olive oil and water, mix them together, let them separate, and then test to see where the drug has dissolved. If there's more in the olive oil, then it's more lipid soluble, so it would be able to diffuse through those membranes. Ions, which are charged particles, are not lipid soluble, so they will not diffuse through the membrane. And then a pKa is an important concept to understand here. pKa is the pH at which half of the molecules are ionized, so the pKa of the given drug, let's say it's 9. At pH of 9, half of those molecules would be ionized and half would not. Acids become more ionized at higher pHs, which are more basic pH. Bases become more ionized at acidic pHs, or lower pH. Remember, 7's neutral on this scale. It goes from 0 to 14. It's a logarithmic scale. And again, 7's neutral, lower than 7 is acidic, and higher than 7 is basic. Since the pH at the intestinal lining is acidic, the book gives a value of about 3.5, a base would be almost completely ionized at this site, but an acid would be only slightly ionized. And the example in figure 1-7 and the discussion of that figure points out that the base, therefore, since it's ionized, would not diffuse through the membrane very well, but the acid would be able to. Another important point here is that really we're talking about the speed of absorption rather than whether it would absorb. Think about, even if something is almost completely ionized, that still means that a small amount is unionized and could diffuse through the membrane lining. Once that small amount was gone and into the bloodstream, a new equilibrium would be reached in the amount of drug ionized and not ionized, so more drug would become unionized and would be able to diffuse through the membrane. Traditionally, with transdermal administration, you would apply a salve or an ointment to aid the absorption of the drug into your system. And for the past several decades, patches have become available. Basically, a membrane controls the release of the drug, so that the drug is released over some period of time. Nicotine patches have been around for a very long time, and now patches are also available for use as contraceptives or pain control and other applications as well. The distribution of a drug is just discussing where the drug concentrates. It tends to concentrate in specific places. We've already discussed lipid solubility as a factor in whether a drug can diffuse across membranes or not. This also affects whether a drug would accumulate in fat. And then ion trapping can occur where there's different pH. The fluids on different sides of the membranes have different pHs. The pK of drug, remember, is what determines its ionization state. So if it's base, it tends to be ionized in acidic pHs, and acids tend to be ionized in basic solutions. So then drugs can become trapped on one side of a membrane, which just means that they can't diffuse across the membrane. And also remember that pH is a log scale, so a pH difference of 1 can cause a 10-fold concentration difference across the membrane. A pH difference of 2 would be a 100-fold concentration difference. A little bit more on distribution of drugs. First is distribution within the central nervous system. You know about the blood-brain barrier, which maintains the balance of chemicals in the brain and in the central nervous system. And one point here is that some areas of the brain are more permeable than others. Then types of transport across membranes. We've discussed diffusion, which is a type of passive transport, quite a bit. This does not require energy. And then I just very briefly mentioned several slides ago active transport, which does require energy. Generally, proteins are embedded in a cell membrane, and they can transport molecules across that membrane. And this can happen even against a diffusion gradient. They can pump an ion or a molecule or whatever it is that's needed to be somewhere. They can pump it against its diffusion gradient and to make it extra concentrated. Another type of transport across membranes is with carrier proteins that basically escort a molecule to the other side of the membrane. And then one last point here is protein binding, which can sometimes render a drug inactive because the drug never reaches its site of action. But at other times, it can act as a depot and just very gradually, very slowly over time, release the drug. Metabolism uses enzymes as catalysts to allow reactions to happen. And the example in the book in figure 1-10, the book goes through alcohol dehydrogenase's role in breaking down ethanol. Alcohol dehydrogenase, the name of that means that it removes a hydrogen from alcohol. So when it does that to ethanol, it forms acetaldehyde. And that's just one step in the breakdown of ethanol in your body. A drug goes through metabolism to form metabolites, and actually that's the same vocabulary when we're talking about food. We talk about metabolites and metabolism. And then any drugs that are ingested through the digestive system will be metabolized in large part at the liver, and liver enzymes are the key catalysts of metabolism for drugs in the digestive system. To talk about excretion or elimination, we start with the kidneys, and there's an illustration of a nephron in figure 1-8 in your book. So the kidneys regulate the level of salt in your blood, the level of byproducts, waste products. They filter everything out of your blood and then selectively reabsorb what your body needs and lets the waste pass to the bladder. That reabsorption is carried out according to the same principles we've already discussed, that being pKa of the molecules being reabsorbed, diffusion, active transport, all those types of things that we already talked about. The nephron is the functional unit of the kidney, and each kidney has millions of nephrons. It's basically a long tube, and again, there's just capillaries surrounding that tube so that your body can reabsorb what it needs. With first order kinetics, you can describe the rate of excretion with a half-life. That's the rate at which half of the substance is metabolized, and that's illustrated in graph A of this figure. This is from figure 1-9 in your book. This example is nicotine, which has a half-life of 30 minutes. So every 30 minutes, you see that its level drops to half of what it was, from 100 to 50, from 50 to 25, and so on. This is first order kinetics. It'll asymptote is the vocabulary word. It'll approach zero, but it never quite reaches it. After a few hours, it's effectively zero because it's down so low that you can't detect it anymore. Then the bottom panel shows zero order kinetics. The example here is alcohol is excreted at a constant rate. So rather than following a curve like nicotine does, alcohol in your system is excreted at a constant rate, or a straight line on this curve of level over minutes. There are several factors that can affect the metabolism of any given drug. Enzymes can be activated, or enzyme induction can even mean that there's more of a specific enzyme that can cause tolerance. The examples of these different things in the book, they give the examples of St. John's wort in box 1-1 and alcohol dehydrogenase in figure 1-10 in the discussion of that figure. Then activity of the enzymes can also be decreased. This is called inhibition, enzyme inhibition. The example that the book gives here is antabuse for use in people who want to cut their drinking, alcoholics. Another factor that can affect metabolism is age. So often enzymes are less active in very young children and in elderly people as well. The top graph in this slide is figure 1-11, and it shows a theoretical absorption curve, a theoretical excretion curve. The absorption curve is assuming no excretion, and the excretion curve is assuming instantaneous absorption and distribution throughout the body. The resultant curve is the more interesting one, and it shows absorption and excretion happening together, which is what happens. It's a more realistic picture of what's happening in your body. So this is just looking at concentration of a drug over time. The bottom graph on the right shows different time courses of theoretical time courses of drugs administered in different ways, different routes of administration here. So you can see going from IV down to oral, which is abbreviated PO. IV is absorbed almost immediately, but it's also the first one that's excreted. If you look at the time, it's at very low levels when other methods of administration are just starting to peak. Oral is the slowest to be absorbed, but it also lasts the longest. So you can imagine that with different drugs, you might have different time courses where sometimes you need immediate effects and other times you want the effects to last longer. You remember ED50 and LD50 or TD50 from earlier in our discussion. There's a certain level that a drug needs to reach in order to be effective, and you want to stay above that level if you want to have any effect, but you also need to stay below the level where you would see unwanted side effects. So the therapeutic level, you can think of as similar to the ED50. The drug must be above the therapeutic level to be effective, but the toxic level you can think of as the TD50. The drug needs to remain below a level with toxic side effects, that toxic level. So a larger therapeutic index of a drug means that that therapeutic window, the distance between those two levels, would be wider, would be larger. And a safer drug has a very large difference between those two levels, so that you've got a lot of play in your dosage before you start seeing toxic side effects. Tolerance can raise the therapeutic level, which then narrows the therapeutic window and increases the risk of toxic side effects or overdoses.